نبدأ دكتور زكريا.
Okay.
Okay, let's start. We are live on Facebook also.
Okay.
Good evening, everyone. We are so happy to host Dr. Zakaria bin Tahir this evening from Morocco. Dr. Zakaria, he was graduate from King Al-Hassan Al-Thani University. He did his DDS and PhD in there. He's a worldwide lecturer in Europe, in Asia, and in Latin America. He's going to speak about surgery, about the risks and the benefits of orthodontic surgery. I think these days it's very important to speak about this topic, especially that we have different options meanwhile after the TADS and maybe even the repositioning by Giorgio Firelli for the midline shift and mandibular repositioning. I think we have to revise our borders in orthodontic surgery. So I think this topic is very important. You are most welcome, Dr. Zakaria. We are so happy to host you. Thank you very much. And the stage is yours. You are most welcome.
Thank you, Doctor. Thank you, Dr. Ahmed. We share my screen. Dr. Ahmed, I can share it?
طبيعي.
Okay. Where is my presentation? Okay. Oh, excuse me. Oh, sorry, 1 minute. Oh, can you see the screen now?
No, not yet.
Okay. Sorry, 1 minute. So this is my screen, so I can share it now.
Okay.
It's okay. Can you see the screen now?
Yeah.
Okay. Thank you very much, Dr. Ahmed. Thank you very much. شكرا جزيلا على الاستضافة. يعني أود أن أحاول أتكلم بالعربية لأن المغربي ما نظن أنكم تفهموا المغربي.
Dr. Zakaria, if you can speak in English, it's better because we have hosts from Turkey and from Europe.
Okay. Sorry. I wanted to start with some words in Arabic because for me it's important for two main reasons. First of all, because I'm with my friends and brothers from Palestine, but also because it's Palestine. And Palestine for Morocco, it's one important country for all Moroccan people. Thank you very much for hosting me here today. And I will try to share with you my small experience about surgical and non-surgical treatments. So before I start, I want to present myself in 3 minutes. I live in Casablanca. I'm not from Casablanca. I live in Casablanca, but I'm from north of Morocco. Casablanca, it's the biggest city in Morocco, more than 3 million inhabitants in Casablanca. It's a new city, not more than 1 century of existence. And if you want to visit Morocco, I will not say avoid Casablanca, but it is not a typical city. It's not a typical city of Morocco. Casablanca is well known by this movie of Ingrid Bergman and Humphrey Bogart. But this movie, I think for the new generation, they don't know this movie. The Casablanca is well known by this mosque. Until I think 2000, it was the third most important mosque in the world after Mecca and Al-Medina. The special thing in this mosque is constructed above the water. The 2/3 of this mosque is constructed above the water. And if you have occasion to visit us in Casablanca, you must visit this mosque. I'm a teacher in Hassan II University. This is a group of students. We have 2 masters, full-time master and part-time master. We have 8 students a year, and this is one group of our students in our treatment units in the university. We have a collaboration with foreign university, mainly French university. Here at the bottom, you have a Moroccan student with French student, and we go once a year, 1 week, to give lectures for free for all students, Moroccan and French students. And we also have some collaboration with other European universities, like here in Poland, in Poznan. And I had the honor to be invited by our professor and friend, Dr. Abbas Zahir, 3 years ago. I went with the 2 French colleagues to give a lingual course to the Egyptian students. It was really a fantastic experience. And I want to seize this occasion to thank Dr. Khalid Abul Azm and Dr. Abbas Zahir for all what they did to gather all Arab society to be together in the Arab Orthodontic Society. We have also a small activity of research. I worked during 11 years and I did my PhD on bonding, on biomaterials in general, mainly in bonding, but this is not an important activity in our university. And once a year, we try to share our experience with doctors in private practice and in public and in private sector. Here we organized a joint meeting with Egyptian Orthodontic Society in, I think, 2018. Yes, in 2018. And we try to invite every year different speakers from all over the world. I think in this session, in 2017, Dr. Batikhi and Dr. Alauddin were present with us. Here the two were the joint meeting with the Egyptian Orthodontic Society, and here we organized also a meeting, a special meeting with our colleague from the Maghreb al-Arabi, from Algeria and Tunisia. And this year we invited some colleagues from Saudi Arabia. We have here Iman al-Namlaqani and Manar al-Jarsifi from Jeddah. And this is the souvenir photo of the last session. And I want to invite you for the next edition. It will be a joint meeting with Moroccan Society and the Arab Society. I am a member of the World Federation of Orthodontic, and I represent the AAO in my country and one of the ambassadors of the AAO, and I represent my country in this association. I'm invited every year in different country, and I have a chance to speak 4 languages, and I give lecture in Spanish, French, and English. And I want to I must say one important thing. I did all my education in French, and I learned Spanish in my parent house. And English came later. So I want you to excuse my mistakes and my pronunciation. The important is the message. So, as I said, I was invited in Asia, in Africa, like here in Zimbabwe, last September in San Francisco. And my friend Nasib Balut invited me to give a lecture in Mexico last October. I gave it in Spanish. And with French colleague, we organized some lingual courses, mainly in Paris. Once we were organized once in Belgium, and we have 2 universities with dental school in Casablanca, one private, and in the private university I was one of the organizers of the adult orthodontic diploma. I have a private practice. We are 12 doctors. I have a chance to work in multidisciplinary team, and this is a chance because we can collaborate, and we can collaborate efficiently, and we serve our patient, and we will try to do our best to our patient. This is the ortho team. I work with 4 junior orthodontists, and I have 8 assistants. And we try to do our best, as I said, to give the best for our patient. And today we will talk about surgical treatment versus non-surgical treatment, risks and limits. Why this topic? I gave to Saad two choices, and he chose this subject, and I think it's a good subject to discuss, because I will show you that in some situation we have a problem to choose between surgery and treatment without surgery. Well, our main activity is we do our main activity only with ortho. The main treatment we do are orthodontic treatments. And if we want to have a proportion of orthodontic treatments associated with surgery, I don't think the proportion is more than 5%. In my case, I have an average of 10 cases treated with orthodontics with surgery. But in these 5% of cases that I treat with orthodontic treatment and surgery, do we have one option of treatment or always surgery? Well, I think for all cases that we need surgery, we have different situations. The first situation are the patient with mild skeletal problem. We can treat this patient with camouflage, with only orthodontic treatment. But these patients are not really in the group of surgical cases, are not important cases in terms of number. The second situation are the severe cases with severe problem, skeletal problem. And in these cases, there is no discussion. We must do ortho treatment plus surgery. Okay. What is the situation where there is no discussion? I think every time we have syndromes, the patient don't come to the ortho office first. They go to the surgeon, and the surgeon send us these cases to prepare the teeth. So these cases are, the patient asks us to improve the facial aesthetic. So there is no discussion in these cases. We must do ortho plus surgery. The second situation where we don't have any discussion is the sequelae of the different problems. Like the first patient on the left side, you have the sequelae of trauma. The second patient is a problem. The patient has already a first surgery step, and the surgery was not good. And the third situation is the situation where you have a skeletal problem, a severe skeletal problem due to infection. It is a case of bone tuberculosis. Okay. In these cases, there is no discussion. We do surgery to improve the facial aesthetic, because patient demand is mainly facial aesthetic. Okay. So what type of surgery we have in our option? We have three options. Late surgery is the most common surgery done to the orthosurgical cases. And this protocol is a classical protocol. We start with ortho, and at the middle of the treatment, we do surgery, and at the end, we have a short period of ortho for finishing. And we have two other options. Surgery first, we can indicate this surgery in some cases, not in all cases, and I will explain why later. And you have early surgery. When we indicate early surgery, Early surgery, we indicate early surgery when we have, for example, when we want, for example, to widen the maxilla. And when we want to widen the maxilla, we must start with first step surgery, and then ortho, and eventually the second step of surgery if we have a class 2 or class 3. So these two situations are the limit situation. And these situations are not frequent in the group of surgical case with skeletal problem. The most important situation are, first of all, moderate skeletal problem in patient, in growth patient. So in this patient, we try to correct the skeletal problem using the growth. But when we have a moderate or severe skeletal problem, we don't succeed always, we don't reach always a good result with orthopedic treatments. The third situation is the situation where we have a moderate skeletal problem without growth. And the fourth situation is moderate to severe skeletal problem. And in these cases, in the case 3 and 4, we also, these cases are borderline cases. And we are always trying to choose between surgery and without surgery. And the majority of our patients don't want surgery. So I want to be honest with you. In near past, I think 7 or 8 years, I started to change my manner to solve this problem in 2011, 2012. And in the past, I always indicate surgery. And if the patient don't want surgery, I refuse to do treatment. And I think now this is a mistake. So in this situation, we have two options. In these borderline cases, we have compensation or orthosurgery. Okay, and we always we are in the middle, and we are not really very sure to choose the first option or the second option. So I put here some important element or point to take in consideration to facilitate the decision. The first point, a chief complaint. We must try to satisfy our patient. So the chief complaint is important to take in consideration. But sometimes the chief complaint, we cannot reach the chief complaint of the patient. The second point is the facial pattern. The facial pattern can help us to compensate the case. And sometimes, even if the case is easy to compensate, the facial pattern can contraindicate this option. Sagittal discrepancy. The sagittal discrepancy is always also important. For example, if we have a middle class, class 3, we can compensate it because the environment can allow us to compensate the case, and the big class 3 cannot compensate it. The dimension to correct, the vertical dimension, the sagittal dimension, which dimension we must correct. And for some dimension, it is easier to compensate than the other. Perio environment. The perio environment is also important because we will push, in these limit cases, the teeth at the limit of the perio bone. So we must take into consideration this bone. And the stability, sometimes we can compensate. And because we are sure that the case will not be stable, we cannot choose for example, the compensation. Psychological profile, sometimes we avoid to treat some surgical cases because if we touch the face of the case, of the patient, we'll have a lot of problems. So we must assess the psychological profile of every patient. And patient motivation. For example, if we use mini screws or other TADs to compensate a case, we must know that this type of option is very hard to use, and it's a longer treatment. So let's start with chief complaint. This first patient is one of my class 3 patient. She came to the office with a precise chief complaint. She wants to improve her facial aesthetic. Well, she's in class 3. She's a symmetrical case. Okay. And in these cases, can we advise the patient to choose other options? It depends on the occlusion. So the occlusion of the patient is in class 3. And if I ask you, can we compensate the case? I think because the class 3 is not too important, this class 3 can be compensated, easily compensated. This is the first element to take in consideration, the discrepancy of the occlusion. Second element is the discrepancy of the jaw. We have a mild skeletal problem, so the case can be compensated. So this is the result we reach. Before and after, we could reach a good result with we reach the main ortho objective, which is the class 1 lateral class 1 canine and molar. And if we compensate the case, we will be satisfied as an orthodontist, but the patient will not be satisfied. So what we did in this case is surgery. There is no discussion, because surgery it's only surgery that can correct the asymmetry. So this is the patient before the treatment. What we do is classical protocol. I don't think I learn something new in these cases. We prepare the teeth, we decompensate, we try to decompensate. We try to create a good decompensation on the anterior teeth to help the movement of the surgeon, of the jaws. So this is after compensation, decompensation, and this is after the correction. And this is the occlusion at the end of the treatment. And the most important thing is the facial result. We could reach a good result, and we could reach the chief complaint of the patient. Not in sagittal view, because the patient don't see themselves in the lateral, on lateral views. They are more interested on frontal view. And the patient, the facial aesthetic of the patient was improved by surgery. And I think we reached what the patient asked us to reach. Okay, this is the 3-step of the treatment before the treatment, after decompensation, and at the end of the treatment. Okay. Second situation, chief complaint. Patient wants to align the teeth and to close the anterior space, and she wants me to do only ortho treatment. So the patient was sent to my office by a Belgian colleague. He did 4-year ortho treatment, 4 years, and the case was not stable. And the patient still had the asymmetry. I can accept only ortho treatment in this case. I can accept it. But I am sure if I accept only the ortho treatment, the relapse will be 100%. The case will relapse 100%. So I refused to treat this patient, even if the chief complaint is not to improve the facial aesthetic. So look at what happened with the first treatment. The first orthodontist wanted to compensate the case, and he pushed, I think, the teeth outside the bone. And even if we didn't have this recession, I think the occlusion is not good. And if I accepted only an ortho treatment, I am sure the case will not be stable. So what we did is look at the cant she had before the treatment. We have an asymmetry with cant of occlusal plane. And what we did is to prepare the teeth and to do surgery, even if the chief complaint, the patient is only ortho treatments. So this is before and after the correction of the occlusal cants. And when we correct the occlusal cant, we can correct the facial aesthetic problem. This is before the treatment, this is after decompensation, and this is at the end of the treatment. So even if the chief complaint, even if the patient don't want surgery, in some cases we must refuse the ortho treatment only because we must know that these cases will not be stable. The second important point to take in consideration is the facial pattern. Look at this patient. If I tell you that this patient is surgical case, we will not believe me. Why? Because the facial is, there is no important aesthetic problem in facial view. So the patient came to my office after first treatment of ortho. She was not satisfied. And even if the patient has no big skeletal problem, you will see in the lateral cephalogram, in the radio, you will see the importance of the sagittal discrepancy. And because she has no big problem on his facial aesthetic, this patient, if you touch them with surgery, you will have a big problem. So if we can compensate the case, good. If we cannot compensate the case, we can do only an ortho treatment without correction of the occlusion, sagittal occlusion. Look at this case, adult patient with limit period situation in the anterior teeth. We have a recession here in the I think 41, yes, it's 41. We have a little recession, and the sagittal discrepancy is very big. And I want you to be always aware about the photos. Photos don't show you all the details. And believe me, when the patient was in the chair, the problem I saw at that moment was very, very big. So look at this. We have at least 5 millimeters to correct. And with this perio limits problem, I was afraid to correct it only in ortho. But I had a problem with the facial view because the patient don't have a big facial aesthetic problem. So what we did is to correct it only with ortho, but with special tool. Why? Because in this case, if you try only with elastics, you will lose a lot of time. So what I decide in this case is to put always an appliance like Forsus to try to correct the class 2. from the beginning. I don't use elastic. I try to use elastic only for finishing, like in this case. At 6 months, at 9 months, and at 17 months, we start finishing with elastics. But the correction of the occlusion, always with a special tool like a forceps. This is the occlusion at the end of the treatment. We reach not a perfect class 1. We still have a small class 2. But I want to notice what happened here. Look at the recession. I think we have a little more recession before than after. And in these cases, we can take in consideration only the photo at the end of the treatment. But in these cases, we must see the patient 1 year and 2 years and 3 years after the end of the treatment. And in this patient, you will see more recession in these lower incisors. But at the end, the most important thing for me is the correction of the occlusion, the stability, and even if we don't improve the profile because the patient didn't have a big problem at the beginning of the treatment, at the end of the treatment, look at the face of the patient. It seems that we did surgery. Excuse me, I have a question here. Thank you. So it seems like the patient received surgery, and we treat it only with orthodontic. And this is the mistake I did in the past. In the past, I refused to use only ortho treatment in this patient, and I think it's mistake. We must give another chance to our patient and using simple tools. Yes, I use TAS, but believe me, we can reach a good result only with elastics, and we can use other special tools in the special situation. Special pattern. What can we offer to hyperdivergent? In the previous case, we had hypodivergent patient, and then we know we can compensate these cases in 3 dimensions: in transverse dimension, and sagittal dimension, and vertical dimension. But we cannot do this option. We cannot choose this option for patients with hyperdivergent. Why? Because we know that this patient will relapse. This patient came to my office with a special demand. The patient, the parent asked me to do something for this incisor. And what can we do for this incisor? We cannot do prosthetic because we have a big incisor. If we extract, we will have a bigger problem. We will lose a lot of bone, and the patient will lose. If he loses the bone, we will have the problem to do implant when we will be adults. So because these cases, we had another 2 centrals on the left side, what we did is take the second centrals of the left side and put it on the right side. But this option obliged me to not think to the surgery after. Why? Because if we choose this option, we will have an ankylosis. And in this patient, we have a chance. Look at the pattern of the face, hyperdiversion. So because I choose to put the second central on the left side, to put it on the right side, I choose the ortho option, compensation, even if the patient have bad patterns for compensation. So what we did, so this is before, after transposition, and the end of the treatment. The occlusion, good occlusion, yes. But this occlusion is a stable occlusion, at the long term, I don't think it's a stable occlusion. Why? Because in this pattern, when we push the lower incisor forward, we know that every time we push the lower incisor forward in the hyperdiversion, it will relapse. So I did this choice because I did a transposition of the upper incisor, but I think I will see the patient in the future because he will relapse. And the second problem in this case, even if the smile is good, the profile is not good. The result in the profile is not good. In some situation, the facial pattern cannot allow us to do ortho treatment. Look at this patient. No big problem in with facial aesthetic, and the patient came for ortho treatment only. Excuse me. So with this occlusion, can we do ortho treatment with this occlusion? We cannot do the ortho treatment with this occlusion. Why? Because we need to correct the skeletal problem, and then after we can level the curve of the spear and to correct the occlusion. And in this situation, the surgery is important, even if the patient asks us to do only an ortho treatment. And in these cases, if you don't do surgery first, you cannot do the ortho treatment, and you cannot choose the classical protocol. So in these cases, because we choose surgery first, the most important thing for simulation is to use 3D and softwares to simulate the surgery, and then after to make a splint with 3D printer, and then after the splint is more accurate with these tools than with classical tools when we send our models to classical lab. This is the occlusion at the end. So the facial pattern is an important point to take in consideration if we want to choose between compensation and ortho surgery treatments. Sagittal discrepancy. Well, every time we have a big skeletal problem, we try to don't use compensation. But there is some difference between the cases. The most important thing to take in consideration is crowding in these cases. Crowding, for example, the class 3 upper arch, for the class 2 lower arch. If we have, for example, in class 3 more crowding in the lower arch than in the upper arch, we cannot compensate these cases. This case is a surgical case because it's a big class 3. So patient and the mother of the patient don't want surgery. And in this case, it's really a big class 3, more than 7 millimeters. And the problem, we have crowding at the upper and the lower jaw. But we have a small chance that the crowding in the upper jaw is more important than in the lower jaw. So I said to the model that I will try to do my best. If I don't succeed, we will move to surgery. She accepted. So we look at the discrepancy, sagittal discrepancy. Too big for compensation. But because I had big crowding at the upper arch, I decided to try without surgery. This is the final result. It's not a good result. I feel very not comfortable when I reach this result, especially in the transverse dimension. But this is a compromise solution. Patients don't want surgery, but I think this is a solution we can offer to our patient. We could compensate the case. Why? Because, as I said, the crowding helped me to widen the maxilla in the sagittal dimension and in a little bit in the transverse dimension.
Excuse me, Dr. Zakaria, can I ask a question about this case?
Yes.
In the pre-treatment lateral cephalometry, is the cephalometry in the centric relation or the centric occlusion? So is there any habitual closure in this?
Yes, it's important. This is a good question. We have a little, I think I remember 2 millimeters of functional protrusion.
Pushing the mandible forward.
Yes. But even if we push the mandible in the centric position, we still had a big sagittal discrepancy.
Okay.
This is the final result. No problem, no improvement on the frontal view, but in the smile, we could improve the smile, but look at the transverse correction. It's not a good correction, but I think it's a good compromise. It's not very bad. This is the correction on sagittal view. I think we improved a little bit the profile. Class 2, hyperdivergent. Like what we said previously, every time we have a hyperdivergent, we will have a problem to compensate it. These patients went to 3 or 4 offices, and all the previous doctor, before she came to my office, indicate surgery. And they are right. This case is surgical case. But she didn't understand why we indicate always surgery in her case. You know why? Because first of all, she's not class 3. Second, because the soft tissue compensates the class 2. Full class 2. Important class 2. Okay. Hyperdivergent. The lower incisor is already in forward position, and periodont is limited in this case. I tried, because she insists to do only ortho, I tried to solve the problem with forceps and TADs. I started pushing the lower incisor forward, more forward. And in the second step, I put 2 mini screws at the upper jaw, to push a little bit the upper arch posteriorly. We reached this result. It's not a perfect result. Look at the relation and in the anterior teeth. We still have 2 millimeters. But believe me, the patient was really very satisfied. And this is important. The second important thing is stability. Is this occlusion will be stable? Why? Because we have a hyperdivergent and we still have class 2. Is this case will be stable? I don't think so. So what we must say to our patient, they must, even if they are satisfied with the result, facially and occlusally, they must wear a permanent retention, a special permanent retention. Which special permanent retention? Upper splint, lower splint, put it together. And she must wear this splint all the nights. The fourth important point is the dimension to correct. We can compensate some dimension more easily than other dimension. I think the sagittal dimension, and especially in class 3, we can compensate it easily than class 2, only with the elastic, and we can correct from the beginning and easily and quickly the class 3. This patient is in class 3, but the soft tissue compensates the aesthetic problem. She has a big face, a big lower. The proportion of the lower part of the face is important. It's typically a typical problem in class 3. We had in class 3. This is the radio. The class 3 is not very big, but I think it's a surgical case. This is the occlusion before we start. I think if the patient had a little asymmetry, so the class 1 on the left side, it's not a class 1, it's really a class 2 because there is a little movement of the mandible on the left side. This is the final result. How we correct this occlusion? Really, it's an easy case to correct with elastic, but we must start elastic from the beginning with the round wires. What we did is to put a bite plane on the anterior lower incisor and then class 3 elastic from the beginning. And in 4 months, we could correct the class 3 occlusion. And then after it's classical steps, we try to finish the case. The problem here, we lose a lot of torque on the lower incisor, so we use a bracket. We invert the bracket to gain more torque because we compensate a lot with elastics. And this is the final result. At the end of the treatment, in the frontal view, when the patient smiled, it seems like we did surgery. And this is an option we can offer to our patient. Why to avoid this option for our patient? And really in the past, I always refused to treat this patient only with auto treatment. Some dimensions are more difficult to correct than others. For example, the sagittal dimension, we can correct more easily than the transverse discrepancies. Look at this patient. This patient came to my office asking me to correct the ortho treatment, and this patient needs a surgery to widen the upper jaw because she had a class 3. A class 3 naturally compensated, but in the lateral occlusal relation, we must widen the jaw. And in these cases, mostly in adult patient, it is really very difficult to compensate the transversal dimension. An important thing, we can compensate easily the transverse dimension if we had a hyperdiversion. If we had the hyperdiversion, is more difficult. And in this case, we had a lot of problem to compensate the transverse occlusion. We reach this result. It's not an ideal occlusion, but I think it's uncompromising. The problem is this occlusion will be stable or not. I don't think it will be very stable, but we say all these details to the patient before we start. This is before and after, no correction in sagittal problem because the patient was already compensated in sagittal dimension. No problem in the profile view. And we improve the smile because we move lateral teeth labially a lot. So she has a dental smile after the treatment rather than before the treatment. Perio environment. The perio environment is important to choose between the two options, between compensation and surgery. this patient is in class 2, and we have always the same problem with the surgical skeletal problem with class 2. They don't understand why we indicate surgery, because even if we have a big gap or big discrepancy in the sagittal, in between the upper jaw and the lower jaw, they don't understand why we indicate surgery. You know why? Always because the soft tissue compensates the problem. So this patient came to my office with a symmetrical occlusion. We have here a full class 2 on the right side and full class 1 on the left side. And the problem is the soft tissue and the perio problem she had in the anterior lower incisors. And the second problem is the sagittal discrepancy. How can we push this incisor forward without provoking some perio problem? And we started the case with a perio problem. So, can we compensate the case? The patient refuses the surgery. And in the past, as I said at the beginning, in this situation, I always refuse only ortho treatment. And from 7 years ago, I tried to change my way to treat my case, even if I don't reach a good occlusion result at the end. So I decided to try compensation. I always say to the patient that I will try. If I reach a good result, it's okay. But if I don't reach a good result, I will stop in the step where the risk is too high. So I try to compensate between the upper and the lower jaw. How? By opening the space of the lower absent first molar on the left side. So when I put the coil, I push the teeth forward. So this is the direction of the compensation, and with a little stripping on the upper jaw. Because it's not sufficient to use only elastic and coils to correct this malocclusion, I used, in this case, unilateral forces to correct the class 2 on the right side. And with the stripping and with some elastic, I reached this result at the end. Look at the relation at the anterior teeth between the upper and the lower jaw. It's not really perfect. It's not perfect relation, but I think it's a good compensation, a good compromise, because we reach, even if we don't reach a good contact on the anterior teeth, I think we reach a class 1 on the right and on the left side. This is the occlusion before and after, 16 months of the treatment. And this is the patient. No improvement on the facial view, because this is a class 2. And the class 2, as I said, we have a soft tissue which compensate the skeletal problem. Before and after. Stability. Important element. We want to finish all our cases, ortho cases or ortho surgical cases, or all the cases, all our cases, we want to finish it, and what we want to have is a stable result in the long term. And I learned a lot with this patient. She came to my office asking me only ortho treatment. And when I saw this facial pattern, I refused to treat her with only ortho treatment. I think 12 years ago. And she refused my option, ortho surgery, and she disappeared 2 months. She came back to my office and she accepted my option, ortho surgery option. Well, she had not a big class 2, open bite, and open bite, we know how to correct it with ortho treatment. We have a risky perio in lower incisor, and look at what happened during the treatment. I started the treatment with orthosurgical option. And during the treatment, the open bite closed. And at this stage, she asked me, why you want me to do surgery? I came to your office only to have this result. Why you want me to do surgery? And believe me, I was confused. And I told her, yes, we can try to continue only with ortho. And we started using a lot of elastic to correct this small class 2. Believe me, more than 6 months with elastics. The class 2 is still here. And as I told you at the beginning, when someone shows you photos, the photos don't show all the details. And look at what the situation, the relation, the occlusal relationship at this situation. Is it a good result? No. Is it a stable result? Never. It will be never a stable result. Why? If I show you only this view, it's maybe a good result. But look at what we have in the anterior teeth. If I debound this case in this situation, it will relapse in 3 dimensions. The open bite, the class 2, the hybrid, all will relapse. So we decided to do surgery in this case. We reach a good result in occlusal. We have a good relation in the lateral view of the occlusion. And this is the result on frontal view 1 year after surgery. Stable result. And this is the important thing too. We can compensate it, yes, but it will not be stable. Second problem, look at what we provoke on the lower period. We push with our elastic the lower teeth forward. We push the lower teeth more than the limits. So we provoke the recession. So we must take in consideration stability and also the perio environment. This is the final result. I think it's a good result, even if the patient don't ask us to improve her facial view, but believe me, she was really satisfied and she didn't regret this option. This is on frontal view before and after. Psychological profile. The psychological profile is also important. Why? Because in some situation, it's clear we must do surgery. And if we have a special psychological profile, we must avoid surgery. We can offer compensation, or the third option, alignment, and leave the occlusion with class 2 or class 3. But the mistake we can do in some special patient is to offer surgery even if the facial aesthetic there is no big problem in facial view, and if the profile of the patient is not you are not certain that if you do surgery, we don't have some psychological problem with the patient. This patient came to my office. He was treated in Paris. My professor sent it to me. And he came with this skeletal pattern. And when I examined his occlusion, I remember he was in class 2, big class 2. And he gave me his radio before the first treatment. He was in class 3, and I told him, you give me a wrong radio. And he told me, no, these radios are my radios. And I told him, why you are in class? He told me that I was in class 3. I did a first treatment, and the surgeon moved the jaw and he put the jaw in class 2. Oh, what can we do with this patient? He wanted to improve his face and view. Look, he was affected psychologically, so the surgery is a unique option for this patient to correct his problem. So what we decide to do is, look at, this is my radio. Before my treatment, he did a first surgical treatment to correct the class 3, and now he is in class 2. So what we decide to do is to retreat the patient with ortho to prepare the teeth, and then after to do a surgery to correct the class 2. This is the final occlusion, and it's true that we could not improve a lot the facial, because he didn't have a big facial problem, because he moved from class 3 to class 2, and we said that class 2 there's no big problem with aesthetics, but he was so affected that he tried to improve her facial. Even if he did the second surgery, he was not satisfied, because he always felt that something is wrong in his face. So what he tried to do is to do some other surgery to improve, for example, the chin, and I don't know how we can call it in English, this part of the face. So he put up 2 prostheses in the upper jaw to improve the facial view. This is before and after. Finally, patient motivation. We can, in some cases, choose compensation option with some devices. But we must tell the patient that these options are very difficult option, and he must know that the period of the treatment probably will be will have a big period of treatment. This patient came to my office. Chief complaint is gingival smile. She's a student in medicine, and because she had a big, she's hyperdivergent, and with a big gingival smile, I told her that we cannot correct this problem with only ortho. So she came, well, she did a first treatment with, the first ortho reached this result. We don't have a good torque on the upper incisor, not good occlusion lateral, but the chief complaint of the patient is gingival smile. Look at what happened with the first treatment. Look at this incisor. This incisor must be, the torque of the incisor must be corrected, first of all. And after, we can move to surgery, after decompensation. What type of surgery? Impaction and class 2 surgery. And we can also do, in these cases, genioplasty. But when we decompensate the case, the patient told me, and even if she accepted at the beginning of surgery, she told me that if I can do something without surgery, she will accept. But surgery, she don't want to take a risk to do surgery. So we tried with mini screws. I don't like this type of option, but in some cases we can offer this option. But look at the period of the treatment, 31 months. Our treatment on average is 18 months and sometimes 24 months. But when we have more than 24 months, the case can start to be very, 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 very difficult for the patient, because he loses motivation, and for ortho, because he at the end tired with the case. So we tried to solve the problem with many screws, and we could intrude the upper arch. Look at here the difference, the difference between this photo and this photo. Look at the amount of the intrusion. We cannot have a lot of amount of intrusion in the posterior teeth. On average, we have between 1 and 2 millimeters on the posterior teeth. But because we have a hyperdivergent, we can move counterclockwise the occlusion plane. So we could intrude. Look at here the relation between the I don't know how we call it in English, the sinus, between the posterior. How we call it, Dr. Ahmed?
Sinus, the same.
Sinus, between the sinus and the upper molars. We intrude the upper molar, but not too much. But the upper incisor, we intrude, I think, a lot. This is the final result. It's not also a good reason. We still need to do a gingivectomy to improve the smile, and this is the torque is not. We could reduce the torque on this incisor because we have a little gap between upper incisor and lower, but I think it's a good compromise. And this is the final result. And in this case, we could, with the intrusion, we could move a little bit forward the lower jaw and reduce, because we have a rotation, counterclockwise rotation, we could reduce the class 2. This is the final result. And thank you very much for your attention.
Thank you very much, Dr. Zakaria. Thank you for this nice and valuable presentation. Really nice results. So I think you're still fasting until now. The iftar is after maybe 10 minutes or 20 minutes in Morocco.
Don't problem. We can stay for questions. Don't. I have tamra. Huh? We can take our time. Don't worry about this.
تفضل. في كان سؤال من الدكتورة حلا، أو بالأول في من الدكتورة نوال. دكتورة نوال كانت تسأل إذا كان في if there was any TMD problems in the case, in the class 3 case, which I asked about.
Yes, yeah, no, yes, I know the case. No TMD problem?
Yeah.
No TMD problems. And we have a chance, we know the TMD problem. I don't know how you solve the TMD problems. The TMD problems, we have three main situations. And even if we have a problem like a displacement of the discs, I don't think it's a big problem. We can manage it with some medicine and some problem. But in this case, to have a clear answer, I didn't have any TMG problem.
Okay, Dr. Man Dhafer is raising up his hand. I don't know. I'm trying to unmute him. Dr. Hisham, you can speak.
شكرا. أول شيء يعطيكم العافية دكتور أحمد، دكتور سعد.
English, Dr. Hisham, because we have people, not Arab people, listening to us.
طيب يلا. Thank you, أخي زكريا, for this valuable presentation. I have two questions. First of all, why did you try to use microimplant to do, for example, in class 2 cases in mass retraction instead of using forces? My second part of question, it's about forces. Did you use this device for the growing patients or for all the type of patients to correct the class 2?
Okay, I will start with the second question, Dr. Hisham. The forces, I use forces in two situations. in adolescent patients that I feel that the motivation is not good, I directly avoid to use elastics. So I put forces every time I feel that the patient will not collaborate. In adolescent patients. But in adult patients, I use forces than elastics when the discrepancy is too big. I don't use elastic, at least for correction of the occlusion, if the discrepancy is big. I started my mind with forces. Okay. This is the two situation where I use, and as you see, Dr. Hisham, that I can use it in adult patient in one side or in both sides. No problem. When you use it in only one side, you will have a little kink created by the force of the force. But it is not the problem. You can correct this problem, this side problem, side effect with elastic finishing instead.
Okay.
For the first, if I understand, can you repeat the first question, Dr. Hisham?
Yes, sir.
The first question, in cases of class 2, for example, and you did class 2 elastics or forces, did you try to use, for example, using TADs, distalized mass for the upper arch, for the full
دخل الرئيس طبعا هذا الرئيس تاجر.
Okay, I understand your question, Doctor. Rather than to use forces, why don't use TADs at the upper arch? Okay.
To do distalization,
Yes, distalization. I understand your question. Dr. Hisham, in most class 2 cases, we have a problem in the lower jaw. In the upper incisor, it's in good position. And I choose this option when I have an upper incisor little forward, or when, even if I have like a patient I show you with a big class 2 and hyperdiversion, when I have a big class 2 and I cannot compensate all the class 2 with moving a lower incisor forward. So I leave this option because in my daily practice, I use really the TADs. I don't use a lot. And believe me, Hisham, I know that you are educated we are educated at the same school. We can reach a good result, even if the severe skeletal problem, only with elastics. Okay.
Thank you very much.
I have a question from Dr. Ma'an. Dr. Ma'an, تفضل. معن باطي. اوكي دكتور رياض البطيخي تفضل.
الله يعطيك العافيه دكتور زكريا.
شكرا دكتور البطيخي، شكرا.
محاضرتك جيده. It's very nice.
شكرا.
Two questions or two comments. One,
okay.
If we have adult case and the problem is the maxilla, either you go for surgery or you go for extraction. Am I right? TAD alone or distalization in upper arch is very difficult. This is the first question. When you have adult case, severe class 2, either you go for extraction, camouflage, or surgery to move the maxilla backwards. Am I right or wrong? Other things you do will not help. Right? First one. Second one is that my comment, don't guarantee our results. Relapse will happen. How much you are, after 20 years, 25 years, you will see the cases and you will see that there's a lot of relapse for our cases.
Mm-hmm. The second question is, I think, the most important question we can ask ourselves in our daily practice. What will happen in the near future, on the middle future, or in the long term. We know when we, in some cases, and I've shown some situation like what I will say, that if we, in some situation, if we choose compensation, it will not be stable. And in this case, we will, in this situation, we must tell the truth to the patient, and they must be aware that they must, if they want to how can we say it in English? If they want that the result,
keep this stable.
To keep the result in the long term, they must put long-term retention.
This is what I mean, is that they have to understand that we need long retention, not 5 years or 10 years.
Yeah, long-term retention. But believe me, Dr. Riyad, in the most cases I show, like in the class 3 case, if we have a good stable occlusion, it's stable. The class 3 I shown, the big class 3 I shown, I still saw him 5 years after. And we know that we don't need to wait more than 6 months to see the relapse. After a few months, we can notice that the case will be stable or not. And in this case, the most cases I show, they are really, really stable. But this is because we did, I think, a good choice. But in some cases, we put always a long-term retention. Can you please, Dr. Riyad, can you repeat, please, the first question? I didn't understand the first question.
About skeletal class 2.
Skeletal class 2,
in adult cases that we can't use headgear or we can't use functional braces, and the problem is maxilla. Either we go for surgery, for extraction, or for surgery.
Okay.
What about your opinion about this?
Okay.
That the problem is the maxilla, adult case, severe skeletal cases. You cannot compensate it by simple proclination of the lower and retoclination of upper.
Yes.
So sometimes, in some cases, even myself, 5% of my cases is extraction and 95 non-extraction. But in some cases, skeletal class 2, the problem is maxilla. Either I go for surgery or I camouflage for extraction by first premolars.
Okay. Okay. Important question. I don't, Dr. Battihi, tell us something important. I didn't show any case with extraction, and he's right, because we can compensate cases doing extractions. But the problem with extraction in the class 2, the majority of the class 2 are the class 2 with the mandibular problem. And when we control the upper incisor, the upper incisor is in good position. We can, if we extract, we will have a big aesthetic.
I'm saying about maxillary problem, not mandibular problem.
Yes. But we can, for example, you said an important thing, that we can compensate doing extraction the upper jaw, so we can compensate the class 2. But in the majority of class 2, we have a problem on the mandible. And in class 3, we have the opposite side. Most of people coming with class 3, they say, "Oh, I have a big mandibular," and it's not true. The majority of class 3, it's a small maxilla. You know what? The majority of surgeons try to move the mandibular backward in the class 2, and this is a mistake. And for the problem of the class 2, we have also the option of the surgery on the upper jaw. But the problem of the upper jaw, surgery of upper jaw, we cannot move it more than 2 or 3 millimeters backward. Why? Because we have an anatomical we have, I don't know, pterygoid.
Pterygoid plate,
exactly.
Complex.
And the third thing that we try to do is to do a trauma on this side of the jaw to move a little bit, but we cannot gain more than 2 or 3 millimeters of it. I think,
Prophet, it's just 2 millimeters.
Yes, 2 or 3 millimeters, not more. So this is an option. The option Dr. Battihi gave us, they must be options in our arsenals, but they must not be the most important option in the treatment of class 2, because we have, in extraction case, we have a problem of aesthetic result at the end, and with surgery, we will not move back. We cannot move backwards a lot the aperture.
Okay, thank you, Dr. Zakaria. We have a question from Dr. Nawal, but it is in French. I can't.
Yes, I can translate it.
Yeah.
You have how you change your occlusal plan. Your occlusal plan. How you change your treatment plan from non-surgical treatment to surgical treatment. Well, this is a discussion you must have with your patient at the beginning. If you say to the patient, you are a surgical case, you have 2 options. We can try without surgery. In the limit case, not in the limit case. In the case we saw that we can try to do, not in the limit case. So this is the discussion we must have with the patient. They must be aware that this option is not a good option. We can try with surgery, with ortho, and if we cannot reach a good result, we must either stop or to move to surgery.
Thank you. Thank you very much, Dr. Zakaria. I think we have finished the questions. If there is
أنا في عندي سؤال كان.
Dr. Hala, تفضلي. Yes, please, Dr. Hala.
Thank you very much, Dr. Zakaria, for a very nice lecture.
Thank you.
Hello?
Yeah. Dr.
Okay. For the period case, I noticed that there was a loss of the lower incisor, right? Am I right?
No.
There was a triangular.
Yes. Good question. Good question, Hala. Good question.
But okay. I noticed that I thought that there was a loss of lower incisor. So I thought if you open the space for the lower incisor, it might make the treatment easier. No?
Yes, Hala. So I can show the case quickly. So. What is the here? This case, Hala.
I don't see it.
Okay, excuse me. I think this case.
Yes, this case, right?
Okay.
Yes, there is a triangular.
4 incisor. But because she had a lower molar absent, we have an asymmetry, and she had a diastema here, opened here, with a perio problem. But we have 4 incisors, not 3 incisors.
4.
4.
Yeah.
And because we had an asymmetry, it helps to correct the sagittal discrepancy.
Yeah. Yeah. Thank you very much. Can you show the result, please?
Yes. The end of the treatment?
Yeah, end of treatment.
This is the occlusion. And this is the occlusion laterally. It's true, we don't have a good result in the relation between the lower incisor and the upper incisor.
Thank you very much.
Welcome.
Okay, Dr. Zakaria, thank you very much. It was a pleasure for us to host you, and I hope that we will keep in touch with you. I saw some names. I would like to say hello for them. Dr. Jihad Al-Baroudi from Syria and Dr. Joseph Bousserhal from Lebanon. It's an honor for us to host them here. It's an honor for us. They are with us. So best regards for them. And thank you very much, Dr. Zakaria. Hope to.
Say 2 words in Arabic now.
تفضل.
Arabic.
Yes.
شكر جزيل. شكر جزيلا للاستضافة. والله لما I posted the poster of a Palestinian Orthodontic Society, believe me. يعني المغاربة هنئوني وهنئوني وهنئوني. شكرا جزيلا لكم، وإن شاء الله نكونوا we will keep in touch.
ان شاء الله.
شكرا دكتور، شكرا لك دكتور، شكرا.
الظروف اطيب من هيك دكتور زكريا، وان شاء الله يعني المغرب في القلب ولا دكتور زكريا، وكل العرب في القلب.
شكرا.
شكرا لك دكتور زكريا، شكرا لك دكتور سعد. معك.
I posted the webinar in the page of Arab Orthodontic Society Saturday at 12 o'clock. Welcome if you can participate with us.
ان شاء الله. الدكتور سعيد الاسطل wrote a comment. Merci beaucoup دكتور زكريا.
Yes, Dr. Astal, he usually come to Morocco to our meeting. Thank you, Dr. Astal.
Inshallah, we will all come to Dr. Zakaria. Thank you very much. And hope to host you personally, face to face here in Palestine very soon. Inshallah.
Inshallah. شكرا دكتور سعد. شكرا على الاستضافة.
احنا تشرف لنا دكتور تصور هنر. شكرا لك.
شكرا. I'm ending the meeting. See you. افطارا شهيا دكتور زكريا. شكرا جزيلا.
شكرا.
السلام عليكم.
السلام عليكم.